In this video, I'm going to explain in detail about the kinematics of shoulder abduction. That is your integrated actions of various muscles in the shoulder complex in order to abduct your shoulder to your full shoulder abduction. That is your 180 degrees of abduction. So coming to the introduction. So based on the scapulohumeral rhythm, which was coined by Inman regarding the 1:2:1 ratio. So there will be 2 degrees of movement in the glenohumeral joint and 1 degrees of movement in the scapulothoracic joint. So that means both your glenohumeral joint as well as your scapulothoracic joint contribute for your abduction motion, full range of abduction motions. So coming to the muscles, I will be telling in detail about the glenohumeral abductors and scapulothoracic upward rotators. So the integrated actions of all the muscles together creates a normal abduction movement. So that is normal abduction, that is 180 degrees of abduction. In order to achieve that, there will be 120 degrees of glenohumeral abduction motion, which will be provided by your glenohumeral abductors, and remaining 60 degrees of scapulothoracic upward motion that will be provided by your scapulothoracic upward rotators. So I'm splitting into 2 joints, that is your glenohumeral joint muscles, and next is your scapulothoracic upward rotators muscles. So first is your glenohumeral joint muscles. So the prime muscles that abduct the glenohumeral joint are your anterior deltoid, you can see here, anterior deltoid, middle deltoid, and the supraspinatus. So the anterior and middle deltoid and the supraspinatus muscles are activated at the onset of abductions. So they are known as the initial abductors. So up to 90 degrees of abduction, this muscle will be contracting and producing the abduction movement. So the maximum level of activation reaching between the 60 and 90 degrees of abduction, that is a point where the external torque due to the weight of the arm approaches its greatest levels. So the maximum contraction will be occurring at the 60 to 90 degrees of abduction. So coming to the role of rotator cuff, in a healthy shoulder, the rotator cuff muscles control much of the arthrokinematics of your glenohumeral joint. The line of force and location of the supraspinatus muscle is ideal for directing the arthrokinematics of your abduction. So you can see here, this is a beautiful pic explaining in detail about the integrated actions of various muscles in the glenohumeral joint in order to abduct your shoulder. So that is your glenohumeral joint contributions. So you can see here the deltoid muscle is having a superior directed force, and supraspinatus, which is horizontally arranged, and this muscle is having a medially directed force, and the remaining rotator cuff muscle, that is your subscapularis, infraspinatus, and teres minor, is having a inferiorly directed force. So contraction of your horizontally oriented supraspinatus produces a compressive forces into the glenoid fossa. So these compression forces stabilizes the humeral head firmly against the fossa, against the glenoid fossa during its superior roll. So you can see here, because of the contraction of the supraspinatus, the head of the humerus will be rolling superiorly, and the supraspinatus rolls the humeral head superiorly. At the same time, it restricts the excessive superior translation. So it not only superiorly rolling the head of the humerus, it also prevents the excessive superior translation of the head of the humerus by your contraction of the deltoid. So because the deltoid is having a superiorly translatory directed force, so the excessive superior translatory force will be prevented by your supraspinatus. At the same time, it will be helpful for producing a superior roll of the head of the humerus. So in addition, the remaining rotator cuff muscles, that is your subscapularis, infraspinatus, and teres minor, have a line of force that can exert an inferiorly directed force. You can see here it is exerting an inferiorly directed force on the humeral head during abduction to counteract the excessive superior translation force produced by the contraction of your deltoid muscles. And apart from that, there is some passive forces from the other muscles, that including your latissimus dorsi and your teres major, so which are stretched. So during abduction, these muscles, your latissimus dorsi and your teres major, are stretched. So they also exert an inferiorly directed force on the humeral head. So the deltoid will be superiorly translating the humeral head. Excessive superior translation will be prevented by the supraspinatus muscle contraction, as well as supraspinatus is also responsible for superior rolling of the humeral head, and the remaining rotator cuff muscle, that is your subscapularis, infraspinatus, and teres minor, along with your latissimus dorsi and your teres major, will be preventing an excessive superior translation by your contraction of the deltoid because of the inferior pull of these muscles. And finally, during your abduction, in the end range of abduction, the infraspinatus and teres minor can also externally rotate the humerus to varying degrees to increase the clearance between your greater tubercle and the acromion. So in order to prevent the impingement, shoulder impingement. So the infraspinatus and teres minor not only produce an inferior translation, it also produces a external rotation motion at the glenohumeral joint at the end range of your shoulder abduction, that is nearly to your 180 degrees. The muscles that actively abduct the shoulder produces relatively large compressive forces across the glenohumeral joint. These joint forces reaches 80 to 90% of the body weight in a position of 90 degrees of abduction. So in the 90 degrees of abduction, there will be around 80 to 90% of the body weight compressive forces will be produced by the muscles that is actively abducting the shoulder. So coming to the pathomechanics. So in case of deltoid paralysis, the supraspinatus muscle is generally capable of fully abducting the glenohumeral joint, although the abduction torque is much reduced. Similarly, with the supraspinatus paralyzed or its tendon completely ruptured, full abduction is often difficult, although it can be achievable. But for some persons, however, full abduction is not possible because of the combined weakness and altered arthrokinematics of the glenohumeral joints. Full active abduction is normally not possible with paralysis of both your deltoid and supraspinatus. So if your deltoid and supraspinatus is paralyzing, both muscles are paralyzing, means full active abduction may not be possible. So coming to the upward rotation that is produced by your scapulothoracic joint. So upward rotation of the scapula is an essential component of elevation of the arm. So these muscles provide the stable attachments for your more distal mobilizers such as your deltoid and your other rotator cuff muscles. So in this diagram, you can see the axis of rotation of the scapula upward rotation. So this is the axis of upward rotation is situated near the acromion. So and this axis is passing in an anteroposterior directions. So this axis allows a convenient way to analyze the force couples produced by the combined action of your serratus anterior, lower trapezius and upper trapezius. So in order to upwardly rotate your scapula, there is a force couple formed by the three muscles, that is your serratus anterior, lower trapezius and your upper trapezius. So these force couples rotates the scapula in the same rotatory direction as the abducting humerus. So in order to abduct, there will be some rotatory motion occurring at the humerus. So the humerus will be going for rotatory motion. At the same time, the scapula is also going for a rotatory motion. So that is your upward rotation. So the mechanical axis or mechanical force of each of these three muscles act simultaneously. So you can see here the serratus anterior, the pull of the lower fibers of the serratus anterior on the inferior angle of the scapula helps to rotate the glenoid fossa, upward and laterally. So because of the serratus anterior pull on the inferior angle of the scapula, the glenoid fossa will be rotating upward and laterally. So these serratus anterior fibers are the most effective upward rotators of the force couple because of their larger moment arm. So you can see here the serratus anterior have a larger moment arm comparing with your other muscles, that is your upper trapezius and lower trapezius. So hence serratus anterior, because of its large moment arm, serratus anterior is the most effective or main muscle for your upward rotation of scapula. So next comes your upper trapezius. Upper trapezius produces the upward rotation of the scapula indirectly by its superior and medial pull of the clavicle. So upper trapezius will be responsible for pulling the clavicle in a superior and medial direction. So because of this pull on the clavicle, the scapula will be going for upward rotation indirectly. So next muscle is your lower trapezius. Lower trapezius also upwardly rotating the scapula by its inferior and medial pull on the root of spine of the scapula. The lower trapezius produces a inferior and medial pull on the root of spine of the scapula, thereby producing a upward rotation. So the mechanics of your muscular force couple formed by the three muscles, that is your upper trapezius, lower trapezius and the serratus anterior, is analogous to the mechanics of three people walking through a revolving door. So as shown in the superior view, this is the top view or your superior view, three people pushing on the door rail in different linear directions. This produces a torque in the same rotatory directions. So each person that is they are analogous to your each muscles. Three persons, three muscles. So this is the serratus anterior, upper trapezius and lower trapezius. So each person or muscles acts with a different internal moment arm. So that is drawing to an actual scale. You can see here, serratus anterior will be having your higher moment arm comparing with your upper trapezius and lower trapezius. So this contributes to cause a substantial torque in a similar rotatory directions. So because of the different moment arm acting in a different direction, this all produces a similar rotatory motions. So all this produces a rotation in a similar directions. That is your abduction movement. So in addition to the force coupled mechanism produced by your serratus anterior, upper trapezius and your lower trapezius, it also assists with the posteriorly tilting and external rotation of your upward rotation scapula, which is most evident as the shoulder approaches full abduction. So during full abduction, you can see here there will be not only there will be your upward rotation of scapula, the scapula will be going for a posterior tilt as well as the scapula will be going for a external rotations. So which is produced by the kinetic interaction of your muscle, that is your three muscles, that is your serratus anterior, lower trapezius and the middle trapezius. So these motions also produces a force couples. So that is this force couple is formed by your serratus anterior, middle trapezius and the lower trapezius. In order to upwardly rotate, there will be a force couple produced by the three muscles, that is your serratus anterior, lower trapezius and your upper trapezius. But here in this case, the force couple is formed by your serratus anterior, lower trapezius and your middle trapezius. So you can see here the lower trapezius pulls inferiorly on the scapula and the serratus anterior pulls the anterolaterally on the scapula. Serratus anterior pulls anterolaterally on the scapula. So this simultaneous muscle action produces the posteriorly tilt in an upwardly rotating scapula. So posterior tilt is formed by the inferior pull of your lower trapezius and your anterolateral pull of your serratus anterior. So this produces a posterior tilting in an upwardly rotating scapula. And next your middle trapezius, you can see here the middle trapezius pulls medially on the scapula and the serratus anterior pulls anterolaterally on the medial border of your scapula. So this simultaneous muscular action produces the external rotation in an upwardly rotating scapula. So apart from your normal upward rotation, there will be some posterior tilting as well as external rotation occurring at the end range of your shoulder abductions. So when the shoulder complex is approaching the full abduction motion, so at the end range you can see here, see the posterior tilting of your scapula as well as external rotation of your scapula along with your normal 60 degrees of upward rotation of your scapula. So coming to the summary, you can see here the prime abductors of your glenohumeral joint includes your middle deltoid, anterior deltoid and your supraspinatus. And this diagram explaining the integrated actions of your rotator cuff muscles as well as the other muscles in order to abduct your shoulder. That is your glenohumeral joint. So this is the kinetic interaction between your upward rotators as well as your glenohumeral abductors. So this is a kinetic arc produced by your two motions, that is your scapulothoracic upward rotation and your glenohumeral joint abduction. So this together produces a kinetic arc, that is your full range of your 180 degrees of abduction. So apart from your normal upward rotation, there will be some other motions also occurring at the scapulothoracic joint. So that is your posterior tilting as well as your external rotation of your scapulothoracic joint. So why it is important? So understanding how these axial scapular muscles control the scapula is a prerequisite to an effective design of exercises or other efforts aimed at correcting the abnormal scapular motion during abduction or flexion. Such correction may ultimately reduce the stress on the soft tissues surrounding the glenohumeral joint and those tissues residing within the subacromial space. So knowledge of your normal kinematics or normal biomechanics and the pathomechanics is important in order to prevent the excessive stress occurring to the particular tissues, as well as in order to produce or in order to set a set of exercises, we need the understanding of your basic biomechanics as well as your pathomechanics of each joints. Thank you for watching this video. Please do subscribe this channel and share this video to your physio friends and community. Thank you.